Good evening, chairpersons, ladies and gentlemen. I'm going to discuss young MI. Do we need a different approach? Answer is the approach is no different essentially, but one needs to individualize and tailor therapy to the existing risk factors, etiological factors, and types of MI. The management strategy, as far as the reprofession strategy is concerned, adjunctive therapy, conjunctive therapy, timelines, there is no difference. And the MI descends silently into the young hearts in most of the situations. And MI in the prime of life could be devastating, and the tragic consequences for family, friends, and occupation could be catastrophic. Look at the prevalence of CAD in the young. Autopsies of young adults under the age of 34 showed that 50% have intimal atherosclerosis. In an IVAS-based study of recently transplanted hearts, mean age being 33 years, the prevalence of disease was more than 50%, with 1 in 6 teenagers manifesting coronary lesions. Now, histological sections of coronary arteries autopsied in the victims between 15 and 34 years old of accidents showed the high prevalence of advanced atherosclerotic coronary artery plaques and vulnerable plaques. So long-range prevention of coronary heart disease must begin in adolescence or young adulthood. Young MI in the study in UK, it was observed that young Indians had 10 times more risk of developing MI as compared to the white population. Our own Indian data, about 25% of acute MI in India occurs under the age of 40 and 50% under the age of 50. Looking at the risk factors in this study of 522 patients with MI less than 45 years of age compared to 1191 matched controls showed that the risk goes beyond family history. So it's important to reduce smoking and metabolic syndrome in children to reduce the burden of cardiovascular disease. The INTAR study data showed those who are less than 53 years of age had higher prevalence of dyslipidemia, smoking, psychosocial factors, diabetes, hypertension, and abdominal obesity. This study from a western part of the country of 787 patients, the mean age of about 35 years, showed that family history was present in 12% of patients, tobacco consumption in 50%, and interestingly, lipoprotein A more than 30 milligram per deciliter was seen in 15% of patients. And this showed an acute short-term outcome in this group of patients was favorable, particularly when they received timely reperfusion therapy. And thrombolytic therapy, they used streptokinase because of the constraints. A word about types of MI, minocard drugs, and familial hypercholesterolemia. In these patients of 3,800 number of patients, type 1 MI was in 55% and type 2 MI in 32%. Those who had type 1 MI, type 2 MI were younger, more likely to be women, and they had high non-cardiovascular comorbidities. And it showed that type 1 MI had 2% in-hospital mortality compared to 13% in type 2 MI. So there's a need to provide more aggressive secondary prevention for patients who experience type 2 MI. And these are the various etiologies for type 2 MI: sepsis, spasm, hypertension, embolism, postoperative, and anemia. And Minoca is another manifestation in patients coming with MI in the young age group. And the Minoca could be due to coronary disorders like dissection, spasm, microvascular dysfunction, or embolism. It could be myocardial disorders and non-cardiac disorders. And you're going to hear more about Minoca in the subsequent talks. About drugs, in 2019, 7 patients who had type 1 MI, median follow-up 11 years, they found that 10% were consuming cocaine or marijuana, and they had worse all-cause and cardiovascular mortality. So there's a need to substance use screening among adults with MI, and the need for counseling these patients to avoid future adverse events. Talking about prevalence of familial hypercholesterolemia in these 1996 adult patients, median age 45 years, 19% were women, 54% had STEMI, 1 in 10 had FH in adult patients with MI. 2 in 10 will have FH in young adults with MI if there is a family history of premature coronary artery. It goes to 4 in 10 if there is a low LDL cholesterol is more than 160 milligram per deciliter. And it goes to 6 in 10 if there is family history as well as LDL is more than 160 milligram. In this group of familial hypercholesterolemia patients, the baseline LDL cholesterol is 180 milligram per deciliter, and unfortunately, only 43%, as 57% did not receive statin therapy before MI, and only 49% of FH patients were discharged on high-intensity statin post-MI. And at 1 year follow-up, again, only 43% achieved more than 50% reduction in LDL cholesterol. And 10% of these patients died during 11 years follow-up. So there is a need for more aggressive lipid-lowering therapy in young FH patients and non-FH patients who develop MI. This is a retrospective analysis of 1 million patients where there are 19% of patients who were in the age group of 18 to 44 years, and they showed smoking, dyslipidemia, and hypertension were most prevalent in this group, and 90% had at least one risk factor. So during first MI in young adults, preventive measures are more likely to be effective. Modified risk factors were highly prevalent and progressively increased over time. So these modifiable risk factors progressively increased over time. So there are plenty of clues to diagnose myocardial infarction in the young. There is no longer the needle in the haystack. Now, looking at the outcome of these patients, in this study of 2 lakh patients who underwent primary PCI, 23,000, 11% were young, in the age of between 20 and 49. This is a Japanese study. The younger group included a higher number of men, higher number of smokers, higher number of patients with dyslipidemia, and higher number of single vessel disease, whereas hypertension and diabetes were less common. And young patients presented a higher risk of cardiac arrest, as you look at this chart here. And they also had higher in-hospital mortality. So the results of this study highlight the importance of primary AMI prevention strategies in young individuals. Now, what is the long-term evolution of premature coronary heart disease? This is in 880 patients, aged 40 years, follow-up of 20 years. They came to conclusion that premature coronary heart disease is an aggressive disease with high rates of recurrent events and mortality. And this all major adverse related were more related to the new coronary lesions rather than the initial coronary lesions. And multivessel disease, diabetes, ethnicity, inflammation, and pursuit of active smoking are all independent correlates of multiple recurrent MACE events. This is the concept of more taking out, less implantation for STEMI in patients who present with non-obstructive stenosis and stable hemodynamics. This again, you will hear more subsequently in the course. Now, so the approach to ASCVD prevention in young adults, addressing risk factors in individuals between 20 to 39 can reduce premature atherosclerotic cardiovascular disease. Tobacco cessation, managing hypertension, diabetes, sex-specific risk factors, and metabolic syndrome are essential. Measuring non-fasting lipids, triglycerides, LPA, and ApoB levels can identify high-risk patients. It has been seen that most young patients with premature MI are not identified as statin candidates before their event on the basis of the recommendations. And most patients with premature MI are not recommended intensive post-MI lipid management. So we're missing an opportunity here. So in young patients presenting with STEMI, blood test on admission should include extended lipid profile that includes cholesterol, triglycerides, HDL, LDL, and LPA. One must administer high-intensity statin and ezetimibe at admission. It's like combination treatment as we use for hypertension treatment. And one should repeat lipid profile 2 weeks, 4 weeks, and modulate lipid lowering drugs to meet the LDL targets. So, chairpersons, ladies and gentlemen, the emphasis should be on primary prevention, and there should be more aggressive secondary intervention. So coronary artery disease in young adults is a hard lesson, but a good teacher. Thank you.